It is my great pleasure to introduce Lee Schroeder. Lee is a clinical pathologist and informatician. He's currently director of clinical pathology at the University of Michigan. I really wish we could have had Lee out to visit because he's really one of my favorite people to talk to and learn from whenever I run into him at a conference. He has an incredibly wide range of interests within the lab and healthcare and out there in real life too. His research interests include laboratory stewardship, clinical informatics and data science, health services research, public health, and he has a particular love for global health. He's traveled widely, particularly in Africa, in the context of his global health work, and has consulted for international organizations like the WHO and Bill and Melinda Gates Foundation. And I believe, though, that he's sticking closer to home lately, given his relatively new role as director of CP at the University of Michigan. Today, he's going to talk to us about drawing conclusions from so-called real-world data, which is data that we find in the EHR, as opposed to data that we collect in the context of a trial or study, which is really a more complicated problem than it might seem. And Lee's going to tell us about it, I think. Thanks a lot for joining us, Lee. Looking forward to it.
Thanks, Noah. That was an excellent introduction. And I just want to say that this grand rounds, as a CP resident, online there wasn't much in terms of resources for CP, and this was one of them. So it was always something I look forward to, and it's a great honor to be able to present now. So this is the talk, and assessing the clinical impact of the lab, causal inference from real-world data. And it sounds like something a biostatistician or epidemiologist would give. I'm neither of those, but I think this is a really important topic. And it's one that I have not been exposed to much in my training, and I think our field doesn't get much exposure, and probably because FDA approval of diagnostic doesn't require utility studies or RCTs. But I feel like it's important. I'll get into that, but I'll be giving you my perspective coming from a clinical pathologist. No financial disclosures to make. So as Noah was saying, a lot of my academic work has been in global health diagnostics surrounding the WHO Essential Diagnostics List, the EDL. And throughout that period of time, as that was being developed and the conferences we were having and the meetings, there was a lot of discussion that we needed a Gavi for diagnostics. So Gavi is the Vaccine Alliance, and that it provides access to vaccines globally, especially low-income countries. And you can see from the report here, they describe how many billions of immunized children there have been, but also the outcome, the impact, the economic impact, the deaths averted. And so the reason Gavi could happen was the business case, the value statement was there for vaccines. The utility studies have been done. And that wasn't the case. It was determined for diagnostics, that the utility studies, like the business case, really wasn't there. And so that's when I really started thinking about how do you establish the value of diagnostic tests. You could have the EDL, but for countries to adopt it and really start investing in it, you need to prove that placing this diagnostic is going to have an impact. And, of course, at home, we have a shift to value-based payments. So this is the CMS 2030 plan, where at the time, current state was largely fee-for-service. I think it still is outside of the inpatient setting. I know that's changing. But, the future state being more value-based payments, maybe even pure, capitation in programs like Medicare Advantage. And in those frameworks, resources are spent, they have to, give back. There has to be value. And the labs are a resource. So I think that there will be more and more scrutiny on the use of laboratory testing. And also, of course, on payments. Payers want to see utility. So where are these studies going to come from if there aren't RCTs? So this is a useful resource IFCC created, the OSLM, the Outcome Studies in Lab Medicine database. So there's about 1,300 plus outcome studies that they've identified here. And you can see many are RCTs, but most of them are actually observational. And they have several different types of outcomes. And I just went through a few, the first 20 I looked at, I pulled out a couple I thought were interesting. So one being high sensitivity troponins impact and ED length of stay, infliximab, therapeutic drug monitoring, improving response, the impact of viscoelastic testing on transfusions, or molecular testing NGS and ovarian cancer on mortality, or the use of tyrosine kinase inhibitors as first line in EGFR mutating lung cancers. And so there's many like this. So what outcomes matter, and what I'm looking at are our institution's goals, key performance indicators. I feel like if I'm doing something that's, the boats are all in one direction, what is that direction? And let's see what the lab can do to improve it. So the outcomes that matter to upper leadership here are access is huge. So are patients getting seen for appointments as needed? What kind of delays are there? Length to stay in the hospital is absolutely huge. Readmissions, of course, healthcare associated conditions or infections. And so these are the metrics I'm thinking about when we're thinking, how can we do things differently in the lab to improve them? And even if you do want to run some utility study with diagnostics that's focusing on morbidity or mortality, they can always be mapped into these utilization outcomes like access or length of stay or readmissions. And that's the language that I think upper leadership, talks in. So this was as a resident. I worked with Nigam Shah, who's at Stanford, who's an informatics and data analyst expert, and he wrote in Health Affairs at the time about the green button for using aggregate data at the point of care. So this was the learning health system concept, where there's not clinical trials for everything, so you can find patients like mine in the HR and see what kind of outcomes they've had with different interventions. It's been slow, but that was like an early seed for me, and I've been really thinking about real world data ever since. And now it's to the point where it's very easy for me and others here at this institution to get data from our research data warehouses to do this kind of stuff. And so real world data in randomized trials, a lot of people have seen this before, but the volume typically much larger with real world data, much more heterogeneous and multimodal, but it's not as complete. There's missing values, and so that has to be accounted for. And then there's errors of biases, lack of randomizations, random errors, non-random errors that need to be dealt with. And that's where the tools of epidemiology come in. And that's pretty much what I'm going to be talking about. And why does it matter? During the pandemic, we saw a lot of headlines of studies that would come and go, observational, studies that had problematic biases. But this was one. This is the hormone replacement therapy story, which for me happened as I think it was first or second year med student, but it was the Women's Health Initiative, RCT, showed that in fact, hormone replacement therapy was not preventive for coronary heart disease and maybe problematic. And that was after years and years of observational studies saying it was helpful. And so this paper goes into taking another look at those observational studies, using observational data to see if they could come up with the correct result that the RCT came up with, and they did. And one of the primary issues was not starting the real world observational study at the time that the patient initiated the therapy. It was just looking at all patients who were on it or weren't on it, but there was an initial bump of risk that was missed if you didn't start looking at someone right when they initiated the HRT. So it was a time zero issue, an immortal time bias issue, and so that turns out to be really important for a lot of observational studies that find something different than RCTs. So there is a debate about this for sure. So, the real world studies are no substitute for RCTs. And one of the arguments is that, yes, you'll try to account and adjust for confounders, but they'll be incomplete and you'll never get there. Versus now Miguel Hernan is one of the champions of this and has done an amazing amount of work. And so he actually did studies looking at HRT, the observational, using observational data to replicate what the Women's Health Initiative RCT found. Did it again with statins and cancer. That was another story where it was thought statins were preventing cancer, but that wasn't the case. And so he was, I think, one of the most important figures in developing this concept of target trial emulation. And so a lot of observational studies kind of focus on what confounders are going to adjust for. But if there's selection biases like that time zero bias, then no amount of correction is going to help. So he's championed this target trial emulation concept, which I'll get into in a moment. But the FDA has supported this too. So this is going back to 2017. This is guidance for real world evidence to support regulatory decision making for medical devices to also have it for drugs. The focus is largely on accuracy because that's what the FDA cares about, the analytic and clinical validity. But the FDA partnered with Brigham for the RCT Duplicate initiative. And when I saw this study, it was a couple of years ago. That's when I really got reinvigorated in this. And so they took 32 trials and clinical trials and tried to replicate them using claims data. And so this is just an example. The two lines on top are treatment and control for the RCT, and the two lines on bottom are treatment and control for the real world data, and the effect size are nearly identical. The 32 studies are plotted here actually on a difference plot, Land Altman. The orange numbers are those where they couldn't really match the inclusion criteria very well. And the effect size differences were greater for those. So except for those two outliers, they were hitting pretty well on effect size estimates using the observational data. And their methodology is this target trial emulation approach, which I'll describe in a minute. I did want to step back and just go over some of the basics of biases. So this was published by Simpson, Edward Simpson, 1951, and it's Simpson's paradox. So the concept is take a population who receives a drug, and in this case, it looks like those who received drugs actually did worse. There are fewer of them recovered than not taking drugs. So it looks like the drug's no good. As a retrospective study, they just pull data from their EHR, say. But if you look at women, they actually improve on the drug. So 73 versus 69, and men also improve on the drug. So that's like, how can that be? And the reason, of course, is that there was not a randomized trial. So if you think about it like this, women are less likely to recover overall. Let's say an estrogen has a negative effect on recovery. So you can see they're about 70% recover on average, whereas men are 90%. But women are more likely to try the drug. So you can see many more of this cohort are women. So of this receiving drug are women. So if you were to randomly select a person who took a drug, they're likely to be a woman, and that's less likely to recover from a randomly selected person who did not take the drug, who would likely be a man. So that is a confounder. So this is this is like a part of a directed acyclic graph, which I'll also talk about. But here you got drug as the exposure, and then recovery is the outcome, and you have a causal line there, an arrow. You're at least positing causality there. But male-female is impacting both the drug, whether you get it or not, because females are more likely to take it, and it's also impacting recovery because women recover worse. So that's it. That is the definition of a confounder, which is probably the most important covariate to consider. But there's two others that I'll talk about. One's a mediator. So if there's a drug that's preventing stroke and it's thought to work by reducing blood pressure, if you include blood pressure in your analysis, then if you condition on blood pressure, then you're going to get confounder biases introduced. So as an example, if you take a population, those receiving the drug here are protected, 83% versus 78. But if you were to stratify by blood pressure, so that low blood pressure patients, you can see here, because the drug worked by blood pressure, if you take all people with low blood pressure, whether or not they took the drug, then the drug may only have some adverse effects at that point, and actually not taking the drug is better. And the same story with high blood pressure. So this is one where if you condition on blood pressure or you put it in your logistic regression, then that will introduce biases in between the drug and stroke prevention or the exposure and the outcome. So a mediator is one you don't want to control for the most part, unless you're interested in the mediation. And then the last one is Bergson's paradox, which is a collider. So this is one where the two, in this case, we're looking at gout as the exposure causing rheumatoid arthritis, which we don't think that's true. But if you were to condition off rheumatology, an encounter with rheumatology, where if you have gout, that influences whether that happens, and if you have RA, that influences whether you get a rheumatological encounter. Then if you just look like in the rheumatology service, that if you're there for gout, you're probably not there for rheumatoid arthritis. So you're going to introduce a negative correlation between those two if you were to condition or include rheumatology visits into your regression. So that's another one you don't want to control for. And this is a type of selection bias. And so you want to put all these things into these DAGs, these directed acyclic graphs. And these are great because they really spell out and make transparent what your thoughts are for causality in your study and your concern for covariates and confounding. And so you always have an exposure and an outcome. And in our case, the exposure will be some kind of laboratory test, probably some strategy, and the outcome will be something downstream. And then you've got your covariates, which be based on the direction of these arrows. Like we say, positing this exposure is influencing this collider, and then this confounder is influencing that outcome. So once you use your expertise to draw these graphs, and then you only correct for the confounders. And the way that you implement that, one way anyway, is through propensity score methods. And so what you do is you make a model using like logistic regression, or you can use machine learning to predict the likelihood that someone gets either your diagnostic like treatment, like the new novel diagnostic, and who is going to get the old one, the standard of care. So based on all the confounders that you think are important that influence which diagnostic strategy, the treatment or the control you end up getting, so you make a model using something, we use logistic regression, and then each person ends up with a propensity score of their likelihood of getting treatment. And then what you can do is, so then everyone has a propensity score, and then you match, you're starting with this large group of those with the treatment and those with control, but then you match, and you can use various matching algorithms. One-to-one matching is an option, where you make sure that there's a pair between those who got the treatment and those who got the control have the exact same or very close within a caliper propensity score. And then once you do that, you take a look and see how well all those confounders were balanced. So that's a look we're looking at on the right here. So before matching, you see these black dots. And you can see there's quite a bit of variation. This is a standardized mean difference on the x-axis. After matching, everything comes in. 0.1 is considered standard. It can go a little higher than that. But this would be considered good balance of these covariates after matching. So it's a way of emulating randomization of old tests and new tests, for instance. And this was a case, this was pulled from that OSLM database. This was the viscoelastic testing versus conventional coagulation on trauma-induced coagulopathy. So it's a study, looking at all patients who had at least one RBC, looked at these two groups, and then had several outcomes, primary, secondary. I don't want to get into too many details on this, but I did want to show this highlighted part in yellow. So you can see here, before matching on the left, there were 3 of their outcomes were significant, including survival at day 28 and length of stay. But then after matching, they lost those 2, but the alive and free of massive transfusion stuck. So in this case, the propensity score matching was an important step, presumably to remove some residual bias. And I'll just say there are some assumptions that go into propensity score methods. So positivity is one of them. This is another word for overlap. So you want to make sure every participant, whether they got one or the other diagnostic test, has a non-zero chance of receiving the other one. So if you were to do a pre-post study, then that would violate positivity, because there's no way someone post would be able to get the test that was available pre. And unfortunately, we do a lot of our rollouts that way, which makes it impossible to do a really well-controlled study. So then you're stuck doing pre-post, or maybe a different study. So that's something to consider when designing your rollouts. The other thing is the assumption is there's no unobserved confounders. And so that's a big assumption. And the best way to avoid that is to have expertise and really lay out that DAG and identify all the potential sources, and then do your best to find that data. And there are some backup processes you can take if you think there's remaining confounders, but it's a big assumption. And then the last one is the stable unit treatment value assumption, that each person's outcome is only affected by their own treatment. So like vaccines and herd immunity would be a violation, and that treatment's the same for everyone who receives it. So now I just wanted to go over a couple case studies. So what we've been working on. So I focused on the long waits. So our huge waits for specialty care referrals. We're going to look at 2 cases. One is celiac testing, one's ANA, connective tissue disease testing. But in celiac, it's nice because there's a clear connection between the blood tests, the serological tests, screening tests, and then to a biopsy. And then if the biopsy is consistent with celiac, maybe there's a diagnosis. So what the intervention was this algorithm, the Mayo algorithm. Essentially, we tweaked it a little bit, but it was, and the problem with celiac testing is that there's so many testing options that if it's just ad hoc or provider preference, they'll be all over the place. And these algorithms are considered to increase sensitivity and specificity. So it starts with total IgA, and depending on your level of IgA, if it's normal, deficient, or intermediate, you'll get different combinations of anti-tissue transglutaminase and anti-deaminated gliadin peptide, either the IgA or IgG versions, or both. And then EMA is also part of this, the endomysial antibody, where if you have a weak positive on the IgA anti-tissue transglutaminase, then EMA is added on, and the IgA DGP. So that is what we consider appropriate. And then we move forward with that. So this is this target trial emulation structure. So when you do this kind of study with observational data, the idea is to create it as if it was going to be a prospective RCT. So you're supposed to define these things. So eligibility in this case would be patients screened for celiac disease with serological testing. And then the treatment strategies are going to be either algorithmic reflex testing, which we call appropriate, versus anything else. The assignment procedure, we just assign according to the EHR data, whoever got appropriate or not. And then we emulated randomization by doing that propensity score matching through adjusting by the confounders. The follow-up period that we're looking for the outcome is 1 year. And the outcome was presence of a biopsy reported in the EHR. So we're looking to see how many patients after their screen end up getting endoscopy and getting a biopsy. And then the causal contrast of interest, it's either intention to treat or per protocol. And this, if we'd taken a step back and looked at orders instead of test results, then we could have done intention to treat. But we just went with test results. So this is more like a per protocol. Now you can adjust for using propensity score methods, adjust for any non-adherence essentially of those who didn't get the test. And that's something we may do, but we haven't done yet. Then the analysis is baseline confounding adjustment by the propensity score matching, like I said, and then at that point you're basically just making ratios to see how many ended up getting endoscopy. But we use you want to control for that matching, so you can use McNamar's or conditional logistic regression, which is what we did. So that's a trial emulation. And this is more like what an informatics person would imagine, is that, this is our SQL query, basically. So we limit it to the first order for each person in the time period, about 10 years. But we wanted to enrich for those screening cases, not for monitoring. So that's why we took the first order. And then we only looked at test results we removed the first year test results and the last year. To make sure there wasn't, any monitoring recently or testing recently, and then made sure we had enough time for the biopsy to occur. Then we pulled the biopsy results and labeled them as positive and negative, and that required some regular expression, string matching. Then we filtered for biopsies that occur within the year. That's the follow-up window. We pulled ICD-10s out to find any ICD-10s that were already present prior to the serological testing, so we could exclude those patients. Joined in those nearest in time IGA results, and then labeled each patient as either having appropriate or inappropriate testing. So even if they didn't order the reflex algorithm, if they ordered tests that were consistent with it, we called that appropriate. And so this was y-axis is just fraction appropriate testing, and then the time is on the x-axis. So you can see a pretty good baseline here, where appropriate testing was about 8% or so. And the sad thing is, actually, we made that whole build right when I arrived, which was around 2014. And then it took a couple of years to realize we never actually went live with it. So we went live here 2017, and that's when you see this bump. And then, of course, it was named something that no one understood. So once we changed the name, then another bump. And now we're up over 80% appropriate testing. So that's that's where a lot of work I've done, stewardship work, kind of ends here. Like, okay, we've achieved it. But then really you want to look downstream. What's the utility on the outcomes? So crude data, the raw data, showed that if you had appropriate testing, there was pretty reduced, it's like 20% reduction in biopsy percentage. So that's actually a huge impact if that were true in terms of people being referred for endoscopy. But we need to do the matching. So back to the DAGs. This is what we created for this study, and in all honesty, we can add more to this, and probably should, and work with GI. I've shared this with GI clinicians, but maybe we could do some more. But you can see here. So the white ones are all the confounders. So you can see the white ones have arrows pointing. Each of these can affect which testing strategy the patient ended up getting, and also impact whether a biopsy was, a patient went for endoscopy. So it's basic demographics like age and race, and we include morbidity in terms of weight loss. Medical service, and now medical service became so important that we ended up doing our matching within each service, so we could have some causal inference within each service rather than using service as a matching variable. But you could do that as well. And then year, this is over a 10-year period, so year is important because practices change over time. And then there are two others. So gluten-free diet is one. So a gluten-free diet is a potential collider because the testing strategy you take because whether you're positive or not could depend on the testing strategy. If you order a lot of tests, something might be positive, which could influence whether or not you go on a gluten-free diet. But then also whether or not you're scheduled for biopsy could influence whether you're on a gluten-free diet. So that could be considered a collider, so we did not include. And then celiac serology abnormality, the test result itself, could be considered a mediator, because if it's positive, then you're more likely to get a biopsy. And also, depending on which strategy you use, you're more or less likely to be positive. So we also did not adjust for that one. And so what our propensity score model looked like this. So we were trying to predict which test you got, appropriate or inappropriate. And we modeled it with these confounders in a logistic regression. And then what you see on the left column here is the raw data. So if we look at everyone we just made this model for, the top left are those who got appropriate testing. And of course, the scores are relatively high because our model is trying to predict who got appropriate testing. And vice versa, for those who didn't get it, the propensity scores are relatively low. But it's a broad distribution. There's a lot of overlap between these two, which is what you want to see if you want to create a matched group. So on the right side is after we did that one-to-one matching using the greedy matching algorithm. You can do optimal ones as well that look for the optimal fit. And there's lots of different analytic strategies for this kind of stuff. But we just used the basic greedy one-to-one. And, so took a person in the treated group who had appropriate testing and found someone else with the same within a certain tolerance propensity score, and then matched them and went through the process. So we also did a full matching. So in full, you don't throw any patients out. You end up throwing patients out with nearest neighbor. But with full, everyone gets a weight. And so if there's someone in the treated who doesn't match anyone perfectly in the control, but you could weight several in the controls, so it'd be a subclass of patients they can match together. So we also did that. And you can see there the matching worked really well. And then here, so after you match on the propensity score, you just want to make sure that each of your covariate, your confounders that you're interested in, that there is pretty good balance afterward. So you can see here in both these cases, those black dots are after matching, and they all fall more or less within that 0.1 standardized mean difference. So the matching worked really well for both of these. But so for nearest neighbor, we start with 40,000, and we dropped half of them in the nearest neighbor matching. With full, you keep them all, but there's an effective sample size because of the weighting, and it was only 2,400. So we ended up using nearest neighbor. Initially we had a 16.5 versus 13.5. It's a big drop. With the match cohort, it was much more modest. It's still lower, but much more modest. But the services were important. So in this sub-analysis, we looked at, this is the y-axis is the biopsy percent difference. So the biopsy percentage in appropriate testing, and how many patients, what percent of them are getting biopsies in inappropriate, taking the difference. And so you can see a couple on the right here, that's emergency medicine. Now, they don't order a lot, and that's probably a good thing. But PEDS also was positive. So with appropriate testing, actually, they're sending more biopsies. And then on the other side, internal medicine is the biggest user, and theirs was negative. And then the next thing was to take a look at the different baskets of tests. And this is a really useful way to look at utilization. And you can see when ordering appropriately, you either order CLIAC, which is our algorithm, and you order these other ones, but they're vanishingly small. Almost everyone ends up just getting the IGA and the TTGA. But for inappropriate orders, it's all over the place. There's many ways to do things inappropriately. So you can see here, some of these have EMA in them and some don't. And that's becomes important here when we map the service types onto these different baskets to get a sense of who's ordering what. So internal medicine is blue. you can see that they're largely in this group here ordering both the anti-tissue transcontaminase IgA and IgG versions. That's kind of the biggest thing, or just the IgA version without getting total IgA. But the emergency medicine and peds emergency medicine, there aren't many of them, but this is where they mostly were ordering, was an EMA and a TTGA. And the EMA is less sensitive, more specific. So it might make sense if they shifted from something with EMA that was often negative to the Mayo algorithm, it might get more positives and may end up referring more. So that's kind of the causal hypothesis there. And then, this was that, like I said, the conditional logistic regression. So if you want to account for that matching structure, so we just did logistic regression where the only predictor was appropriate testing or not, but then you let the algorithm know who's matched to who. And then we end up with this. So these are all odds ratios of getting a biopsy with inappropriate as a reference. And so it's appropriate versus inappropriate. And you can see those in ED, like we saw, the odds ratio is way higher, more likely to get a biopsy if you're using appropriate testing in ED. Same with peds. And then internal medicine was low. And you can see here the internal medicine is quite high. Gastroenterology is also high, but they're difficult to predict what this means because they tend to they kind of have more information, more complicated patients and so forth, referral patients. But then the next step is, are we just sending more or less of the same kind of patient, or are we enriching for higher value patients in the case of internal medicine? And so here's a weighted regression on positivity. So it's a little complicated, but the y-axis here is the change in biopsy positivity. So if you're higher, that means you're getting more positive biopsies. And then the x-axis is the change in biopsy rate. So if you're higher, that means you're sending more biopsies with appropriate testing, like in the ED, which you see these 2 points here. So this is not technically significant if you use 0.05. It's at 0.066. I did do you do Cook's distances to look for leverage points and remove some of those, and then it gets stronger. And if you do more of that, it gets weaker. So, and individual, just looking at binomial distributions, not many of these were positive. Maybe it's a sample size thing. I don't know. But I don't think there's no relationship. So I feel like there's something to be a type 2 error just to say there's no relationship. But it seems that if the biopsy rate's going down, then the biopsy positivity is going up, and then vice versa for these other services. Another way to look at this is just to do a concordance analysis, which what we did. So if it was random, the biopsy positivity and rate, then you'd see dots in all 4 quadrants. But you can see they congregate in this upper left and bottom right, but still the p-value is 0.07. So that's more or less the celiac story. Then the ANA is kind of similar in that there's a lot of tests, right? So IFA is indirect immunofluorescence. And then there's the extractable nuclear antigens, which you're looking for antibodies in the serum against certain antigens. And there's a big debate about which is better, the IFA or the ENA, or starting with IFA and going to ENA, or vice versa. So unfortunately, we call this the NAB, the NAB, nuclear antibodies. So in a couple of figures, I'm going to be referring to it as NAB, not IFA. And so we do have an algorithm that goes the NAB2 to ENA and vice versa. So we're going to be looking at these. Now, this is that target trial emulation. I won't spend too much time on it, but it's very similar. So patients screened for ANA-related connective tissue disease, whoever got testing. The treatment is going to be using these reflex tests versus provider-preferred testing. And the assignment procedures, this is whoever got the test and the data. We're going to emulate with confounders. Follow-up period's also 1 year. The outcome, in this case, would be, did they have a rheumatology encounter within 1 year? And again, per protocol, contrast, causal contrast, and the same propensity score methods. And then logistic regression. So this was, in this case, we took baskets in a 45-day window over this 10-year period, and we removed the first and last year as well. We removed patients who ever had a positive CCP or rheumatoid factor to enrich for those referred for ANA-related disease rather than rheumatoid arthritis. Added the demographics, the rheumatological diagnoses, and so forth. Excluded MRNs with encounters or diagnoses that were occurring before the testing date. And then we ended up, so the outcome, we're looking at the rheumatological encounter and then possibly diagnoses coming from that, which would indicate a high value encounter. So these are our testing strategies over time. We converted each of those market baskets into either all ENA. So all they ordered was some panel or subpanel of ENA, only the IFA or the NAB, one of those two reflex algorithms, or both. So you can see here, the blue is the IFA reflexing to an ENA if it's positive, and we started that in 2019. We just looked at data from 2021 on, so there was that positivity overlap assumption we had. And you can see here, these are the different services. Internal medicine's ordering the most, again. And if you do a stack bar plot, you can see that each of these services kind of represented each of the strategies. There's some there. So it's something to work with in terms of doing a matching study. Now, just as our raw data, this is the rheumatology visit rate by service. So this is kind of interesting. So pediatrics, you get an ANA, and 35% of them end up in a rheumatology encounter, which is the most. Internal medicine is kind of intermediate at 18%, and in family practice, which sends a lot, psychiatry as well, very rarely do these. So maybe that's like a lab stewardship thing. You would need to be ordering so many of these tests. And then on the other hand is the diagnosis. What's the diagnosis rate of an ANA-related condition after the rheumatology visit or at the rheumatology visit? And you can see, so PEDS is ordering the most or getting the most encounters, but they actually have a pretty low, quote unquote, success rate of identifying an ANA-related condition, whereas internal medicine doesn't send as many, but it's higher. It's kind of like the enrichment thing with the biopsy. On the other hand, family practice sends very few, and then they also get very few out of it. So again, a lab stewardship thing, perhaps. But we need to do matching and see what this looks like. So this is those same measures, so the rheumatology visit rate and the y-axis. But let's just look at internal medicine, and it's stratified by the testing strategy. So you can see if you do both ENA and NABs, there's a huge referral rate. Now, probably that represents some kind of referral, maybe patients coming from outside who already had tests or that they knew they were positive. I don't know, probably higher risk patients. These two next to it, the blue and the green, are two algorithms, either going from the ENA to the IFA or vice versa. And you can see those are actually quite close and very low, which is a good thing if you're trying to reduce utilization. And then these last two are if you're just using ENA or just using the IFA or NAB, which are intermediate and also very similar to each other. So we wanted to do pairwise assessments. Our propensity score matching looks very similar, this DAG to the celiac, but the only difference here is that we included some morbidity issues here. So inpatient, outpatient, about 20% were inpatient, and also whether or not there was a CRP or said ESR, whether it was tested and whether it was positive. And then I'm not going to spend too much time on this. These are the odds ratios for getting an encounter. And you can see using propensity score matching. So the coral is the raw data, and then the blue is the match data. And you can see that the pediatrics, there was a decreased odds of getting an encounter using, this is the NAB, the IFA to ENA, starting with IFA versus the ENA the other direction. But on sensitivity analysis, using an alternative version of propensity scores, probability weighting, that disappeared. They got corrected out. So probably not much going on there. And then this is just looking at, as a reference, those just ordering NAB, the IFA versus them getting the reflex from IFA back to the ENA. And here you do see that there's some consistent reductions in the odds ratio for getting an encounter. And then same with the vice versa. So starting either just getting ENA testing or getting that reflex. But these odds ratios are really extreme. And so there's more work to do here. We're meeting with rheumatology to go over this soon to work out that DAG. And then on the diagnostic rates, we didn't see anything. Nothing statistical. The diagnostic rates there was nothing statistically significantly different between encounters that came from one strategy or another. And then this is the last couple slides. So challenges with real world data. So let's see, confounding by indication. So this is this concept that there's a lot of confounders, and it's going to be if they're sicker, they're going to get one strategy over another. And this is something you can fix as long as you can identify all the confounders. Those propensity score methods they work well. But if there's unobserved confounders, then of course you've got problems. And expertise is the best way to solve that, and just make sure you're really thinking about all of them. And there's other strategies, but I don't think we have time to go over that. Then there's selection biases. So just who is included in the study to start with. If you have the wrong people, then no amount of emulating randomization will work. And this includes loss to follow-up and adherence. So if people stop, don't adhere, if it's like something like a medicine stent, they stop, you need to account for that. And if people leave the system, you need to account for that. And that's something, informatics can help with that as well, to be able to see how much interaction does each patient have with the health system. Have they seemed to drop out or not? We actually have not done that, but that would be a useful thing to identify who's actually lost a follow-up, and maybe that's why they didn't get their encounter. Then there's the timing issue, that time zero thing I mentioned. So this is the immortal time bias, which is hugely important for a lot of studies. In our case, we started with that first test. That was our time zero. Data quality issues. So missing is huge, obviously. We have a health information exchange in Michigan that we have access to. So I have pulled from that, and that has helped. There's Care Everywhere within Epic that we use, which helps as well. We need to take advantage of those tools. And then there's, if there's inaccurate or inconsistent records in EHR, then that's gonna be a problem. And then there's misclassification. So errors in exposure of the outcome definitions. So this can be a big problem in claims data where it's not quite clear, or you don't have all the information. When you have access to your entire research data warehouse, the issue then becomes, how can we analyze free text to make sure we're getting the right information out of that biopsy? So that's another informatics problem. And I guess the key takeaways. So hospital labs, I feel, need to demonstrate downstream value, or at least increasingly so, to thrive in the value-based healthcare framework. And also if you have initiatives to get certain tests paid for, molecular tests, having this kind of data is really useful. And the modern causal inference tools that leverage EHR data and claims data, they can incredibly demonstrate this value if done properly. And then I think just to say, think about your next QI project or rollout. Design it in such a way that there is a fair chance someone would receive either diagnostic or treatment option that overlap. Because if you don't have that, then it's really hard to say anything. So some planning in advance is helpful. And that is it. So I appreciate your time. These are my collaborators who have worked on this. And I guess the only thing I might just end on is that there are likely a lot of diagnostic specific biases and challenges that that we could categorize and list. I mean, there are like STAR-D and Quadis, they identify for diagnostic accuracy studies all the unique biases for diagnostics, but the biases for outcome studies, I think, are less well detailed. So that is something I feel like best practice from our field we could be working on. And that is it. So Noah, I think I'll hand it back to you.
Oh, okay. So thanks a lot, Lee. Look, gives us a lot to think about. Super talk. I really enjoyed it. I think if folks could please use the Q&A to ask any questions, and while people are thinking about their questions, I can start with one. So at the end, you talked about care everywhere and health information exchanges as possible sources of supplementary data. Our institution just got access to Epic Cosmos, and I'm guessing you're familiar with that. For anyone who isn't, it's basically Epic's massive data warehouse where they aggregate data from I'm assuming dozens of participating institutions at this point, and they have just absolutely staggering amounts of data that's aggregated. I think there are some issues with it. It's very heavily de-identified, and I think we lose some detail, but it's not the kind of data we've ever seen before, in the sense that we're almost not sampling the population anymore. We're looking at the whole population in some cases. So it just seems, I just really love to get your perspective on that, whether it would be amenable to the same sorts of methods that you described, whether it's just a different beast altogether, and whether you've thought of any use cases for Cosmos. I'm not sure if Michigan has access to it or plans to.
So, yeah, I've heard it talked about. I don't know much about it. Is it de-identified patient level or aggregate data? You said aggregate.
It's de-identified patient level. Sorry if I said aggregate. So you can link patient events longitudinally, and they do some date shifting, and they do some pretty heavy redaction of anything that might be identifying. But there's a lot of stuff in there.
Can I move forward a slide or two? Because I actually have a slide for this. So yeah, this one. Because it's great to do something at your institution, but if you really want to show something like for a payer, then you want it to be multi-site, something larger. And so this is a list of different approaches for doing that. And because of the issues of PHI, federated approaches can be really useful. And Odyssey, OHDSI, is a common data model that, and we had plans to map ours, we didn't, but now there's new plans. But once you do that, then you can use the Odyssey. They have a bunch of scripts to do, written by epidemiologists to do these kinds of studies. And then, if all their institutions also have, then you just pull them in and you run it locally, share aggregated results. And there's all sorts of of centralized de-identified, like Optum Labs, which we have access to, and the IBM Market Scan. And then there's some with PHI, like CMS and others. I have not done it, but you certainly can. I mean, that's what the target trial emulation, the RCT duplicate study was. It was using the PHI data from CMS. I think I don't know what is included in Cosmos. You may run into some more difficulty with, getting details. But if it's everything that's in Epic, in our institution, then, I mean, that seems like an amazing opportunity. And I don't know how it would compare to Optum Labs or Market Scan. But yeah, that is commonly done.
I can ask one more question while we wait to see if there are any others from the audience. So you hinted that there were methods for identifying confounders that might go beyond or might be more I don't know if systematic is the word, or automated than experts just sort of thinking through what might cause confounding. If there was one method that you thought was particularly interesting or promising along those lines, so I wonder if you could comment on that.
Yeah, that there's another slide for that. There's no perfect answers for it, and that's just the reality. There are, if there's concepts of instrumental variables that can be used when that's something, but it's hard to really prove that that's you're using an instrumental variable, which is basically some proxy for a random allocation, like geography sometimes is. But analytic solutions. So one thing you can calculate is an e-value. So you calculate this value of which, given your effect size, how much of a correlation would you have to have in an unmeasured confounder to lose that effect size? And so then if you like suspect maybe there is an unmeasured confounder that you know about, but you just can't measure it, you can calculate the e-value and see if there's any like reasonable way that that correlation could ever be that great as a confounder to destroy your findings. So that's one thing you can and you can model also quantitative bias outcomes, model different confounders and to get a sense like for sensitivity. There's also latent variable models, which I don't know too much about, but it's something. And worse comes to worse, you just link to other data to get the confounders that you think might be out there, or use triangulations of findings. But it's going to be, it will be a problem. One thing you can do too is, if there is an RCT, let's say, then you establish as a benchmark, you use real world data to replicate it. And now so you have your methods to replicate it, and then you can expand because maybe the RCT didn't cover a population you're interested in. So that's a way that RCTs and real world data work in a complementary manner. So that expansion concept, I think, is a pretty strong one that also could be considered. And there is a question. We're almost out of time, but what is the alternative to value-based care? Oh, and can your method be adapted to that? So yeah, there's either there's value-based care or there's fee-for-service, right? Fee-for-service financially, you're rewarded for just doing as many tests as you can, from the silo of the lab. But if those tests are leading to all sorts of interventions that are having adverse effects and not benefiting anyone, then that's going to hurt your population. Now, financially you might be rewarded from all the treatment, but even in the fee-for-service framework, you're still interested in trying to improve care, and so that's something that's going to always be ever present. It's just that when you move to the value-based framework, then everything you do has to be producing value intrinsically. And so it's when these methods become really important.
And if we have one more minute, Susan asked a question in the chat. Are you able to see that?
Yeah. Okay. So different different performance characteristics. This would be, I started putting together a slide about, the diagnostic specific issues. Because like when you're looking at medicines, it's the same molecule for multi-site studies. Now in the case here, I was looking at just whether a test was ordered or not really looking at the test result. So in some way, that's kind of reduced the variability of the test performance and biases and so forth in the test result. But maybe not, because if a certain algorithm is using an assay that tends to run high, then you're going to see that lead to more biopsies. So I feel like this is an important area that would be diagnostic specific, that probably isn't going to be thought about by epidemiologists too much. and it's worth thinking about. That's also important for reference intervals, and reference intervals are really important for referrals. So I think that's a really important topic. Thank you, Susan. And I think we're at 7:30 here, or I guess 3:30, 4:30.
Yeah. Yeah. So many thanks, Lee. Thanks especially for staying late on the East Coast to give this to us, and really appreciate it. And thanks everyone for attending.
Yeah, it was a pleasure. Thank you so much.